And it makes it feasible and sustainable for us to operate, because it's probably not reasonable for us to fund everything we do with private money, because we don't get government money. So it's not, most nonprofits have a huge chunk of their budget covered by a local municipality or federal or state grants. We don't have that. We don't do that. So it's all private money. That the $2 million a year that we raise, it's private money really. So this makes up about $100,000 to $150,000 of our revenue. So it's around 10% of our money each year comes from guest fees, either paid by the guest or paid by Medicaid or insurance companies.
Can I make an interesting?
Please.
So not only, so a couple slides ago we noticed, or we pointed out the income levels and where we were at. So we serve a very large population of individuals at or below 30,000 annual household income. But the data suggests over the past few years that we are seeing a shift in demographics in terms of people or families that we've served. So we're starting to serve more families who identify with more, and again, this is all self-identifying, who make more in terms of annual household income, and those individuals who make more are starting to stay longer at the Ronald McDonald House. So it's interesting. That's another thing that we're going to continue to watch.
And so our assumption, which we don't have proof of, but I feel really confident about it, is that when we had 33 rooms, the hospital, and we were turning away 500 families, the hospitals screened and only sent us their most indigent families. So they sent us the families that they perceived had no resources. They would sleep in their car or the waiting room, which we want to serve. Of course we do. And now that we have greater capacity, that's starting to shift, meaning they don't have to screen for that. They can just send people who are traveling regardless of their means. And the good news about that is it gives us, instead of only having the toughest of the tough, people who have had really tough roads, who are really poor, maybe have had histories with substance abuse or like really significant issues, because I've heard that that creates challenges for us, that now it's a broader base of people, which is, I think, a healthy thing for an organization. Diagnosis. So the big diagnoses, and this is a diagnosis upon admission, and so the other category, so one of the things Mike's working on, or the team's working on, is looking at diagnosis when people check out, because it often changes. They don't know what the diagnosis is, or they came in with one thing and now it's something else as they leave. And what's most relevant is probably when they leave. But anyway, so premature birth, heart, cancer, orthopedics. So if you take out unknown and you take out other, the four top: premature birth, heart, cancer, orthopedic surgeries. And then close behind that would be brain, neurological, burn, lungs, stomach. And then it gets less prevalent with these other conditions. Average length of stay. So for instance, this is an interesting thing that Mike has pointed out. High-risk pregnancy moms. They comprise only 2% of the families we see. So it's a very small percentage, but they stay longer than anybody, right? So they're very few of them, but they stay longer. So that means they're using rooms for longer periods. So that is important to know. Average stay and size. I'm going to skip that in the name of time. Outpatient stays and occupancy. So there's been a gradual increase, and if you look at this over 10 years, it's more significant. But there's an increase in the number of outpatient stays, which means the patient is staying here and receiving treatment at the hospital. Instead of the patient being at the hospital and mom and dad being here, we have more patients, kids here.
We're just following the trends in the healthcare.
That's exactly what's happening. And then occupancy. See that? Length of stay. So it's been fairly consistent over time with length of stay. And is there anything you'd point out on this?
No, other than it's interesting that we're not seeing a huge spike.
Yeah.
And it'll be interesting to watch
when we have 72 rooms.
Yeah.
And we have the 8 long-term suites. So we can look at average length of stay in the long-term units versus overnight stays. And And the length of stay is relevant because for housekeeping and guest services, it matters more the turnover than it does the number of people you serve, because that's what instigates the work, is turning the room. So the longer people stay, the less rooms you have to turn, right? So that informs a lot.
And that's why we're trying to monitor like diagnosis against average length of stay, because then we could maybe one day identify if somebody comes in and they are a high-risk pregnancy and we're putting them in room 301, we could assume that the individual in 301 that room may need to be cleaned in 11.4 days.
Right.
That can allow us to do a little bit of scheduling.
Then this, perfect. This is the turn away trend. So 2014, we turned away fewer families, which is awesome, but it's still a huge number of families. And there's clearly a trend in turnaways, which we are realizing there's a trend in occupancy. So there tend to be high and low months for occupancy and high and low months for turnaways, which is good because then we can plan for it, because we know we're going to have fewer rooms to turn or more rooms to turn. And then guest surveys. So the house. We began in 2013 or 14 with we started guest surveys again, I don't know. Is it 2013 or 14? So we asked guests a series of questions, and basically this is a summary. It's not the entire report, but it's a summary of guest satisfaction. So were they satisfied with their stay? Did they feel safe in the house? Did they feel the house was clean? Quality of the rooms, ease of checkout, ease of check-in, friendliness of staff. So the takeaway for me here is the low. Ease of check-in is the lowest, check-out. So we're paying attention to that because that's what people report as the least satisfactory to them, which is understandable because they've already gone through a whole check-in at the hospital. And then the one thing I want to note is I get a report on the guest surveys, and there's now a section that refers to sort of a shout out to the staff members that made an impact, or the volunteers. And there are a few staff members that are always on there, so which is really informative. So Grant, Anna, Lauren, like there are lots of folks, Casey, I could go on, that are like always noted, about their kindness or their going above and beyond, and I just think that's really awesome. And then family room. So this is a chart that talks about the units served at Primary Children's and Ogden Regional. So you get a sense of where families are coming from. And I don't know, Casey, if you want to point out anything. The largest is the Children's Medical. I don't know. Do you want to say anything about this graph? Since you'll know more. They categorize things differently at Primary Children's than they do at Ogden. So it's not an apples to apples comparison. It's very different because it's a children's hospital versus a regional hospital. And the reason that that is important is that Casey can then see who is utilizing the room and who isn't. So if there's a unit that has a huge number of families that they're serving that could benefit, but they're not using the family room, then that's great to know. Or if there's a unit and they're getting tons of referrals from that particular unit, then they know they have a good partnership going with that unit.
Especially because we are looking at outreach within the hospital, so things like that are really helpful to know as we target nursing staff or the social work staff or whatever the referring person might be. So yeah, that's definitely been helpful in that strategic plan.
Okay, good. And then this is guest satisfaction. So one thing I want to say about the satisfaction as a little disclaimer for the family room is at the house we have a captured audience. So we say, hey, I'll go take a look at your room. Would you complete this survey while I go do that? But at the family room, you don't know when they're checking out. You don't know their last visit. And it's really hard to get the surveys completed as a consequence because you don't have a captured audience. So they served 6,600 families and you had 40 responses to surveys, I think. So that's like less than 0.001% or something of the total. So it's it's probably not as relevant because it's not a proper sampling of the group, but it's something. It's something we have. So we,
Fun
yeah.
tidbit, we are doing surveys now electronically this year.
Sweet.
And we have already like tripled from what we had in 2014.
The whole year,
2015
just in like the
now.
first month, I know.
Yes, so it's been really helpful because we are getting feedback.
Okay,
Both
good.
positive and then constructive as well. So
Constructive, right. Okay, so again, we asked people about overall satisfaction, and as you might imagine, check-in is the least, people least like our check-in process. Okay, that's the program report.
8 minutes. Good job. In the section.
8 minutes, all right. So, okay, good and good. Next section.
Oh. Or Ira.
For Ira?
Whoever.
Thanks, Linda, for covering for us. You're so awesome.
It's all about food.
Okay. I'm going to go through a couple of survey